It's such a pleasure to be here. It's my first time in Rwanda, a beautiful nation. And I was invited by Dr. Agarwal to participate in this course today. I'm an orthopedic surgeon in Boston. I'm the chief of the Department of Orthopedics at Beth Israel Deaconess Medical Center, which is one of the 4 teaching hospitals that Harvard Medical School has. And even though I'm mostly administrating these days, I've been an orthopedic trauma surgeon for 25 years, all the time at Beth Israel. So my talk today is about principles of open fracture management, and I'm actually borrowing a talk that has been presented by Dr. Agarwal in other parts as part of our curriculum as we teach courses like this in other parts of the world. So open fracture management is certainly a very complex issue. Even surgeons who have been practicing for many years find the challenge variable, right? Every case is different. Every case can be challenging in many different ways. And it takes many years of experience and training to try to identify those skills that allow you to perform a good debridement, to make decisions on the viability of a limb. So a lot of this you will learn as you practice. There are some good sources of reading. These 2 books here were designed to present material specific to austere settings and areas where perhaps you don't have all the equipment and all the imaging systems that are useful to help you make these decisions. So I believe, Dr. Agarwal, we have the PDFs for these books, so we can have you make them available to you if you want to follow up in your readings. So the objectives for this lecture are relatively focused. I would like you to understand a bit more by the time we are done today about the acute management of the patient that has polytrauma, because many times the open fracture of the lower limb is just one small part of the whole. Sorry. You're sabotaging me. Good. The second item is understanding principles of evaluation and management, and to identify the path you're going to take as you start providing care for these patients. So, as you know, the global burden of trauma is severe, and in fact, the amount of mortality that happens from trauma exceeds that of tuberculosis, malaria, and HIV combined, right? And that's not difficult to understand when you see the amount of traffic and the as people drive more motorcycles, and it's actually quite the numbers are quite significant. And many times in America we complain that we have a hard time obtaining funding for the study of trauma because all of it is so focused on very categorical infectious diseases or so, and despite the mortality being significantly higher in trauma. And as I was saying, road traffic accidents, natural disasters, and sadly so, violent conflict is a major contributor to trauma and mortality worldwide. This is a slide illustrating that the increase on the incidence of injury, particularly in environments where there are lower resources. If you look at the lower part of the chart, the darker green shows that most of the overall increases happen in countries with a middle and low social development index, which is a measure that is used for assessing economic capability of a particular setting. And so it's challenging, right? if you look at the work from the Global Burden of Disease group in 2017, in a place like Africa and South Asia, it's 90% of people lack the access to comprehensive and complete care, and compared to Europe and the United States and other more developed countries. So this is the problem. The problem is that we are dealing with a very high volume and severity of musculoskeletal trauma, and often have to address it with minimal resources. So what can we do about this? So if our focus today is on because of the nature of the workshop, is in these items, right? So if we are to try to contribute as an organization to focus on items that would be the most impactful to improve the situation, right? We would have to focus on providing and upgrading skill in the practitioners and clinicians that provide this care, because many times there's just not enough of you. There's just not enough of you for the populations of our countries. And then, in addition to the skill and the knowledge that we can deliver through educational programs, provide systems to improve fracture stability and wound management. Because all these fractures, it doesn't help to have a bone that is aligned and healed if the overlying soft tissue is going to result in an infection and a failure of the limb. So with that in mind, the items of the workshop that we will be focusing on today, well, we have the educational conference, it's this setting here, but we're going to be introducing you in the workshop to two devices that have been developed by SONA, which is a nonprofit organization that's associated with Harvard Orthopedics, to provide low cost, economically sustainable instrumentation for the basic care. And we will introduce you to the AFIX external fixator system, and we will practice with some frames, and we will talk about Vatara, which is a very economical and accessible vacuum pump system for wound management. Those are two basic tools for the successful management of open fractures. So open fractures often involve, obviously, high energy mechanisms and polytrauma. They have severe bone, articular, and overlying soft tissue injury and soft tissue deficits, right? High risk of complications, particularly in this short-term infection. Ultimately, even if the soft tissue is viable, you have a high risk of non-union. And improving your initial management will have a significant effect on the outcome. So this is again focused on the initial management of fractures. We usually, this concept that we'll present now is applicable worldwide. There are essentially 3 tiers of acute care that a patient may fall into after an injury, right? So depending on the location and the sites, patients may receive initial care at a tier 1 site. A tier 1 site may be a local location that has potentially no orthopedic specialists available and limited resources. A tier 2 may have some basic orthopedic care, but still be limited in resources such as complex imaging. And then tier 3 is sites that have their tertiary care, where people are transferred to once it's determined that advanced care, proper imaging, and surgical capability will need to be available, right? So a tier 1 site could be a rural health center, a community hospital, or a basic district hospital, and obviously the capabilities of those settings will depend on the resources of the public system that the nation has. Maybe no operative facilities at all, and staff which would be more trained towards general care and not necessarily trauma management. Tier 2 could be a general or district hospital, perhaps with operative facilities, but perhaps not with the imaging that is required to discern some of these complex articular fractures. And tier 3 is places like this. So when you're dealing with fractures, obviously, again, X-rays are essential, right? But many times you may not even have imaging availability, and at that point, the best you can do is provide proper splinting, and we will talk a little bit about splinting in a second. But sometimes you may not even have the devices and the plaster and the frames and the things that you may need for proper splinting. So you find what you can, whether it's something as simple as a box or cardboard or wood brackets. It may be sufficient to provide stability to a wound and to a limb as you proceed with transfer to a higher tier system. When X-rays are available, so the diaphyseal or long bone nature of the injury may be apparent, but when X-rays are available, you should certainly image the joint above and the joint below. So you can see in this case that there is a femoral shaft fracture, but you may not appreciate is that it is accompanied with a femoral neck fracture. Now, who knows what the correlation and coincidence of femoral neck fracture with a diaphyseal shaft fracture is? Any guesses? I'm so sorry, I didn't hear. Yeah, yes, it can be substantial, right? And it doesn't. And this one happens to be obvious, but many times, I admit to have missed femoral neck fractures in my practice at some points in my career because they were not very apparent. So many times the association of the femoral neck fracture to the femoral shaft in a individual who's been in a motor vehicle that they crash is quite common, and the fracture is not displaced, so it can be missed. And if you don't do a CT scan, you may not see it. So even in the situations where we take patients to the operating room without a CT scan, I always try to keep in mind the association of the more typical correlated injuries. The other thing you should obviously do if you have availability of imaging is to get orthogonal views. So what do we see here? We see what appears to be a proximal humerus image of a shoulder, right? And there may or may not be a small lesion there. But what you don't appreciate is that this is a dislocated shoulder. So with a single view, it's never sufficient to do proper diagnosis of the three-dimensional nature of your injury. So orthogonal views are required to properly discern this and not miss it. So polytrauma, managing polytrauma is a bit beyond the goal of this workshop, but clearly the assessment of the polytraumatized patient should start by following your advanced trauma life support, ATLS protocols, right? Associated, obviously, airway, breathing, vascular issues, right? But, from the orthopedic perspective, a couple of important things are required. A single view of the pelvis is critical in the first assessment, right? And mostly because you may find that pelvic injury is not entirely obvious by exam, unless it's associated with an open injury and severe malrotation of the hip. But it could be clearly a very concerning cause of acute severe bleeding and death. And if you have a polytraumatized patient, you suspect a pelvic injury, there's hemodynamic instability, you really should try to manage that. And in first care setting, one of the obvious things you can do is something as simple as a pelvic binder can be life-saving. A pelvic binder, in a case like the one I have illustrated with that X-ray, will close the space of the pelvic cavity, allowing for tamponade to happen as resuscitation is offered. We will not speak much about the spine and cervical spine injuries, but a patient that has been polytraumatized should be assumed to have a potential C-spine injury and should be properly immobilized and boarded for transport as well until proper cervical spine injury can be assessed. So back to the extremities. After the first ATLS stage of care is provided, we focus on the extremities. And this is when we do our orthopedic care. Pain, deformity, wounds that are obvious have to be addressed. Bleeding has to be addressed. And it is okay if you have a patient coming in with a very obvious deformity, such as a twisted limb, to reduce it acutely. Some of those reductions may require some analgesia or some kind of local block or hematoma block that can provide them. We'll have a couple of slides on that. And then it's also very important for the first assessment to include a very complete and well-documented neurovascular exam, because many times the patient may not be conscious later on, and you have an opportunity to document what is working and what is not. And there will be some other findings. You will identify, for example, fractures that may not be open, but at a very high risk of becoming open. This is a case of severe skin tenting on a clavicular fracture. Now, clavicular fractures tend to be benign most of the time. It can be treated most of the time non-operative. But something like this may require some degree of manipulation. If you leave it like this, it will be surely perforating the skin in fairly prompt timeline. So open fractures. How do we treat acutely an open fracture? Well, the first thing you should always do is provide antibiotics and tetanus prophylaxis. And you should probably focus on assessing the limb, its vascularity, removing any gross contamination. Something as simple as an irrigation with saline can clean the wound, and that should not be thought as a debridement. That's just a simple irrigation as a first stage of care. And then you should immobilize the limb with splinting, and then start triaging as to whether you can provide the subsequent operative care at your site, or whether you need to transfer. Because the proper management of an open fracture will require surgical debridement. So there are open fractures, and there are really terrible open fractures. And we have talked in the past of the concept of the mangled extremity. And the mangled extremity is a limb that is severely injured, that usually will include not only fracture, but significant muscle loss, most likely neurovascular deficits, and sadly so, not always may be salvageable. So the goals of treatment in the case of a severely mangled extremity is first stop the hemorrhage, obviously, because that could result in the demise of the patient. Still prevent infection by giving antibiotics and irrigating and debriding the wound, and then stabilize the broken bone to allow the next steps of care. Usually, management of a mangled lower extremity will require complex plastic surgery care. This is just another example. In this case, it's a traumatic amputation where the patient has a tourniquet in place. So if you place a tourniquet in any kind of tier that you're going to be transferring, you must have proper documentation of the time of which the tourniquet was applied, as well as documenting your neurologic exam. One communication tool that is helpful when we talk about open fractures is the Gustilo-Anderson classification. It's very simple, so allow me to spend a minute on this. It's fairly old. It's from the 70s, and clearly there is inter-observer variability when you describe this. But there are three types of open wounds, and sometimes we refer to them as grades. An injury with a Gustilo type 1 injury is not all the time, but mostly a low energy injury. It is accompanied with a wound that is in the order of a centimeter or less. This picture here is a hand with a small radius puncture of the forearm, a laceration over the wound. You can tell whether a small injury such as a grade 1, a type 1 Gustilo fracture, includes open fracture underneath by observing what's coming out. Many times the blood will have the exudate will have small globules of fat, and that's usually associated with marrow blood. The infection rate for this is variable, but this should be treated the same way. Then we skip to the type 2. The type 2s are a little bit more concerning injuries. Again, can be lower energy. This time the wound is less than 10 centimeters, so it goes from 1 centimeter to 10 centimeters. There is no vascular injury at this point. The tissue, there is enough soft tissue to potentially manage this without complex flaps or reconstruction. They carry a higher infection rate. And the type 3s are obviously the more concerning ones. Now we are dealing with a fairly broad range of injury. What is common to all type 3s is that the wound is more than 10 centimeters. And the types can be types A, B, or C, right? A type A is a wound that is 10 centimeters in extension, but has sufficient tissue locally for coverage. A type 2 is a wound that does not have sufficient soft tissue for coverage and will require some kind of plastic surgery care. And the type 3 is like the type 2, but with the addition of vascular injury, which will require vascular reconstruction. So one of the primary goals is to stop the hemorrhage, and simply that can be something as simple as providing direct pressure to a wound, packing wounds with sponges and gauzes, and a tourniquet. If you use a tourniquet, you must document the time at which you apply it. They are most commonly applied on a thigh and a calf. This is a commercial grade tourniquet, but it doesn't have to be something like this. Something as simple as a padded rope or anything that will be sufficient to stop bleeding can be helpful, and document the time at which it happens. So knowing how to place a tourniquet is a very basic skill that every provider should have. So it's particularly regardless of the tier setting you're in. Back in America, I have a small emergency bag in my car, and what I have in it is tourniquets. Because if I'm ever witnessing a motor vehicle crash, that's to the level of my skills, perhaps the most useful thing I can have. So the secondary goal is to prevent infection. And when it comes to acute care, obviously that is the use of antibiotics, and then followed by immediate and prompt, effective surgical debridement. So infection is a terrible complication. It can happen in very high percentages of open fractures. Even with antibiotics, you can have severe infection. But without antibiotics, the rates are very high. They can lead an infection that is, once it happens, it can be quite disastrous. It leads not only to persistent soft tissue loss, it can lead to chronic osteomyelitis and disability that is lifelong, and potentially amputation as well. So when do you start the antibiotics? You start them as soon as possible to the arrival to your care setting. We know that if the antibiotics are given later than 3 hours, they carry a higher infection risk, 3 hours from the injury, that is. And you extend them 72 hours after the injury, well, particularly if the wounds remain open, and 48 hours after soft tissue coverage and fixation. So what do we use? Cefazolin is what's usually used for low-grade open fractures. We add ceftriaxone for type 2, Gustilo type 2. For type 3s, and we use Zosyn in the United States. Oh, sorry about that. But you can substitute for ceftriaxone and gentamicin if Zosyn, which is piperacillin and tazobactam, I believe. Whatever the profile of antibiotics delivered, it can change regionally at times, and with the setting of the injury and the degree of contamination. Don't forget tetanus, right? Now, most folks will have had some type of tetanus vaccination early in their childhood, but if it's been more than 5 years since you have a tetanus booster, you should apply a tetanus toxoid booster at the time of injury. And then we move on to irrigation and debridement. And do not confuse irrigation with debridement. Debridement is a very different thing. You can irrigate a wound as a first care to remove the accumulated contamination, but debridement, proper debridement is the key. And in fact, we have a lecture in a few minutes on proper debridement, so I will not spend too much time on this. And the entire wound has to be debrided. All the contamination has to be removed, and then you have to have the skill to determine what's viable and what's non-viable tissue. And that's very hard, even for someone who's been doing this for many years, and which is the reason why debridement is often serial, because you do a debridement initially and you debride the tissue that is obviously devitalized, but some of that tissue in the zone of injury will continue to deteriorate. So debridements are always serial. Then you proceed to stabilization, and stabilization can be achieved in many different ways. Sometimes splinting is sufficient, but we in this workshop we will be presenting external fixation as well. So one thing that I always teach my young residents is it doesn't matter where the injury is, you immobilize the joint below and the joint above. As part of your initial immobilization strategy. You can perform a reduction either with conscious sedation or even with a hematoma block. So many times a fractured wrist, a dislocated ankle can be managed with a block, with a local block, with lidocaine injected directly into the hematoma of the fracture, allowing a few minutes for that to dissipate and performing the reduction at that point. You'd be surprised how much manipulation of a fracture you can do with a local block. So with that in mind, be prepared. Have your when you present to provide care to the patient, you have to have your soft roll materials, which are the 4 or so layers that you apply, the plaster, the ACE bandages, and the materials for your hematoma block. We use lidocaine. We use lidocaine and an 18-gauge needle. And once you reduce a fracture, if you have the capability to obtain another X-ray to make sure that you did a proper reduction, that is very helpful as well. And then you can apply your short leg splints, typical Jones splint, posterior slab, and a stirrup about the leg if it's something in the ankle. You can extend proximally to the thigh if it's a tibia fracture. Remember, splint joint below and joint above. And then sometimes for foot injuries and calcaneus injuries, we have a tendency to swell up significantly and blister. We use what we call the bulky Jones splint, which is essentially a series of soft wrappings, multiple soft wrappings, something that as much as 2 or 3 centimeters of soft wrapping about an ankle, allowing the rigidity of the dressing, providing protection, but also allowing some room for swelling. Skeletal traction is used as well as a stabilization device. Obviously, the problem with this is the patient is bedridden while they're on traction. And external fixation is a very capable tool. Allows to stabilize multiple parts of your skeleton that have been traumatized. You can apply an external fixator if you know the anatomic principles anywhere in the upper extremities or the lower extremities and even the pelvis. And we will illustrate today a pelvic fixator, some of the techniques and patterns of external fixation application that we use. Because I will not spend much time here. We will go over all these examples of fixation of a tibia in the workshop, including the ankle spanning delta frame, which is a very stable way of maintaining fractures, dislocation of an ankle. And sadly so, many limbs cannot be saved. Some limbs are beyond any possibility of reconstruction, and sometimes the best thing you can do for a patient is to offer an early decision to proceed with amputation. Amputation is a very challenging discussion with the patient. There are individuals who may not want to have an amputation. There are a lot of cultural factors in populations that can accept an amputation versus others that have a harder time accepting it. When it comes to amputation, clearly know your anatomy, control your vascularity. It has to be, you can't close us down. It has to be a clean zone of amputation, proximal to the injury, obviously. And we often do, in a very traumatized limb, we can perform a guillotine amputation as a first stage of care, eliminate the necrotic burden of the limb. The guillotine amputation is usually performed somewhat longer than you would, you're going to have to shorten it later on. And as you start shortening your guillotine on the serial care, you have to start thinking of how you're going to, what kind of skin and soft tissue you will preserve to close the amputation. There will be a lecture today that includes compartment syndrome. But compartment syndrome is a big problem. You should be able to recognize compartment syndrome. You should be able to identify the techniques for a proper fasciotomy release. And we will have, in the cases, we will show some cases that have compartment syndrome today. Most of the problem with compartment syndrome that I've encountered is not the failure of recognizing one, but many times the failure of completely releasing the fascia of a particular compartment. And if you don't completely release the fascia, you are not resolving the problem entirely. So from a trauma perspective, it's better perhaps to do a more extended incision to make sure you have the complete compartment exposed and not something small. I always see transfers coming from other hospitals with very shy fasciotomies. They recognize that a compartment syndrome was developing, but they come in with a little incision like this on the leg, and obviously an improperly decompressed fasciotomy. Missed compartment syndrome is a tragedy. This is an example of a young boy who had a distal radius fracture, and he had some reduction maneuver performed and was casted in a circumferential cast. And despite the child complaining of pain, it took some time for care to be delivered, and by then a compartment syndrome had developed, and the child ended up with a necrotic arm. So reviewing briefly, initial management, initial care of the open fracture is critical. Antibiotic delivery, tetanus delivery, irrigation, and then followed by proper surgical debridement and bony stabilization. And those are the topics that we're going to focus on this workshop today.